welcome back to this educational activity focusing on stroke risk reduction in people with diabetes. I'm back here with my colleagues, Dr. Karen Furie from Brown University and Dr. Alice Cheng from the University of Toronto. Well, I just presented a little bit of new information on the important role of diabetes therapeutics in reducing stroke risk. As we've already discussed, glucose control alone appears to have a very modest impact on cardiovascular endpoints, but we've just heard that the GLP-1 receptor agonists in these large CV outcome trials appear to reduce not only overall cardiovascular events, but specifically the reduction in stroke risk is certainly more prominent that we've seen with other agents. We also looked at some older drugs, specifically pioglitazone, in both the proactive study as well as the IRIS trial. So, Alice, I'm going to start with you. The data on pioglitazone, in my estimation, is quite strong in terms of stroke risk reduction. Remember, IRIS was a study done in non-diabetic individuals who had insulin resistance. So we don't see a lot of use of pioglitazone in the diabetes community, and certainly not in primary care. Why might that be?
So I think it's for several reasons. One is the side effect profile that pioglitazone and the thiazolidinediones as a class can have, such as edema, weight gain. There was a connection with potential bladder cancer as well. And then also there was a concern about increased fractures with thiazolidinediones. So it carried some baggage, but a lot of that baggage was potentially something that could be mitigated, but then what happened was time passed and other agents became available. So as soon as other agents became available, other anti-hyperglycemic therapies came along that were better, right? Better in terms of far fewer side effects, and then eventually the cardiovascular benefits, renal benefits, other benefits that were seen. Then those side effects that pioglitazone may bring became unacceptable in the context of having other choices. So although the data are certainly robust, I completely agree with you there, Silvio. I think it was a function of, yes, there are side effects, but oh, we got other stuff now. So why use this older therapy?
Yeah,
particularly, so I think that's a big part of it.
Particularly the weight loss that you get from some of the newer agents, although
absolutely
it's tempting to consider whether a low dose of pioglitazone could, in combination with some of the newer agents, be effective, specifically in a stroke population. Right. Karen, it really never caught on in the neurology community. Thoughts on this issue?
Yep. So first of all, the patients that were enrolled in IRIS were identified as being insulin resistant using the HOMA, which is not a readily available lab assay. And so it was difficult to be able to translate that into clinical practice when in the hospital we were using fasting blood sugars and hemoglobin A1C. So that was an initial challenge. I completely agree with Alice that the side effect profile can also be daunting, particularly for neurology clinics that aren't set up to do things like weights or to evaluate patients for congestive heart failure. So there was a lot of concern that perhaps these patients were going to be too medically complicated for a neurology outpatient clinic. And then finally is the issue of weight gain. And that's very unpopular with patients. And in fact, we're usually counseling people on the importance of achieving a normal weight and regulating diet and exercise. And so it would be difficult to convince patients to go on a drug that could actually cause them to gain weight.
Alice, I'll start with you on the next question. Obviously, lots of excitement in the diabetes world about these newer agents, both the SGLT2 inhibitors and the GLP-1 receptor agonists, the first drug classes that have been definitively demonstrated to reduce cardiovascular risk. But today we're talking about stroke primarily, and it's really interesting to me to see the differential effect of these two categories of medications, both of which have cardiovascular benefits, on stroke specifically. The SGLT2s, my read of the literature is that they appear to be neutral. There's not been a dedicated stroke trial, obviously, but when you look at the point estimates, they're pretty neutral on stroke. Whereas with the GLP-1 receptor agonists, if anything, the what's driving the MACE reduction in at least 2, if not 3 of these trials has been a very strong effect on stroke. So what is your read? Am I over interpreting what I'm seeing in these clinical trials, these sub-analyses? Is this an important distinction? And lastly, should we be favoring one drug over another based on the underlying cardiovascular disease that that patient has, whether it's coronary disease or cerebral vascular disease?
So to start off, you're certainly not over interpreting what's there. I completely agree with you. The SGLT2 inhibitors do not show us a stroke signal. GLP-1 receptor agonists show us a signal for reduction in stroke risk. And as to why, I mean, to this day, we're still sorting out why either of those classes produce all of the organ protecting properties that they do. We're still figuring that out. And clearly, they're very different classes of medications that have very different mechanisms of action. And the GLP-1 receptor agonists may very well have some more direct or indirect brain effects that the SGLT2 inhibitors do not, as they primarily work on the kidneys. The hemodynamic effects of SGLT2 inhibitors may have led us to think that they would result in stroke reduction, but yet they didn't. So clearly there's still a lot more that we need to understand. And the two classes are different. And the way I see it from a clinical perspective, it's great that they're different. And it's great that there's this separation, or this difference, I should say, because I always joke that it's like you're holding a potluck and you want people to bring different dishes to your potluck. And it's great that you've got SGLT2 inhibitors that are going to give you the heart failure and the kidney benefit. Then you've got the GLP-1s that are going to give you the stroke and the heart stuff. So it ultimately helps the patient. Now, whether guidelines should then separate out, I can tell you clinically, I do. And when I'm speaking to colleagues and they ask the very practical question, how should I choose? I personally do discuss that heart failure kidney person gets SGLT2, no question, first. The stroke person, TIA person gets GLP-1 first, and then the others are a bit of a toss of the coin. Now, for guidelines to make that distinction, though, it may require some more dedicated studies to make that distinction. But I got to say, clinically, I absolutely do make that distinction.
So Karen, many of us don't in clinical practice, certainly at the level of primary care and even in endocrinology. We think of ASCVD as ASCVD, whether it's PAD or CAD or stroke. My sense is that that's probably overly simplistic. And listening to your talk, clearly stroke is very complex. Many different types of stroke, ischemic, hemorrhagic, lacunar, et cetera. So should we consider stroke as a unique disease, separate from just coronary artery disease?
I think we should. The intracranial vessels in particular may have different properties. We know that they don't completely mimic the pathophysiology that we see in coronary arteries, for instance. And I think it would be persuasive if we had evidence that these drugs were particularly beneficial for preventing recurrent stroke, that a more nuanced approach to selecting drugs would actually be implemented. We've certainly seen that in other classes of medications, and ultimately it will benefit patients.
And one point I'd just like to make before we conclude is that, while neurologists understandably are interested in preventing the next stroke in their patients with stroke, it's important to acknowledge that the MACE effect, the overall MACE effect, whether it's stroke or MI or CV death, is indeed reduced with the SGLT2 inhibitors. And there were plenty of stroke patients in these CV outcome trials. So that I guess it's a little bit semantical. Do we want to prevent the stroke or do we want to prevent the MACE? And we want to do everything. But I think coming from the neurological perspective, particularly if you're a stroke patient, yeah, you're very interested in preventing that next stroke. You definitely don't want that. But I think we have to rein it in a little bit because we also want to prevent them from dying from a cardiovascular event and having an MI. I think this is a really interesting topic. Well, we're out of time. Thanks so much, Karen Furie and Alice Cheng, for joining me on this brief discussion.
Thank you.
Thank you.